Well, good afternoon. My name's Chris Burton. I'm one of the nurses, one of the nursing supervisors in our assisted living department. I also manage all of our continued educational needs in assisted living. And we don't have any assisted living employees in here today, but I'm sure I'll still see most of you around. Today we're going to go over a couple of things. We're going to talk about hand washing, some kind of proactive things we can do to keep you and our residents healthy, and then we're going to talk about dementia. Okay? So first, to get us started, we are going to talk about hand washing. It seems kind of silly to have a room full of grown adults talking about how to wash our hands, right? But it's actually interesting. The CDC, the Center for Disease Control, says that approximately 80% of contracted illnesses occur in healthcare settings because of improper hand washing techniques. So how do you think, what's the most appropriate way or the best practice for washing our hands?
Aren't you supposed to sing like your ABCs or happy birthday?
You're supposed to sing happy birthday, right? I've heard some people say recite the Lord's Prayer, ABCs. It's 20 seconds.
Yeah, well, at least 1 to 2 minutes to wash your hand.
Okay. Okay. Certainly longer is not going to hurt anything. All right. So the recommendation is at least 20 seconds. All right. How hot do you think the water should be? As hot as you can stand it. We don't want you to scald yourself, right? But the hotter the water is, the more likely it is to kill bacteria. Okay. And then some areas that you want to pay special attention to: underneath your fingernails, in between your fingers, around your wrists. Okay. Those are all areas that bacteria like to cling and hide out. Okay. And especially if we have jewelry, women, engagement bands, wedding rings, they're notorious for collecting bacteria. Okay, so make sure that you're paying special attention to those areas. So when should you wash your hands? Obviously, anytime you use the restroom, we need to wash our hands afterwards. Anytime you cough, sneeze, or blow your nose, before, during, and after handling food, before you eat, between resident visits, after petting animals. We do from time to time have animals, therapy dogs come through the facility, and you might be tempted to bend down. Oh, you're so cute, can I pet them? That's great, we want you to do that, that's okay. Just make sure you wash your hands afterwards. All right, anytime you touch anything that's been contaminated or anything that you think may have been contaminated. And then really the last one here, anytime that you think your hands are dirty, go ahead and wash them, right? If you find yourself thinking, yeah, maybe I should wash my hands, then you probably already should have, right? Okay. And I get asked a lot, especially by folks in the nursing profession, is hand sanitizer a good supplement for washing our hands? Hand sanitizer is great if you don't have a sink and soap easily accessible, okay? But please make sure if you are using hand sanitizer that as soon as you are able to physically wash your hands, that you do so. They used to teach in different nursing programs that the rule of 3, it was okay to use hand sanitizer for every 3 patients, and then you wash your hands after that. Please don't do that. The best practice is to simply physically wash your hands whenever you have the opportunity to do so. We recognize sometimes life isn't that convenient and you might not have a sink nearby, but wash your hands as soon as you can after using hand sanitizer. Any questions about hand washing? Okay, it's pretty easy stuff to remember. The next topic we're going to talk about is tuberculosis. Okay, tuberculosis is an airborne disease. It is spread through droplets that hang in the air. So basically that means that if you're in the same room as somebody who has an active case of tuberculosis, you're at risk for infection. Okay? It can stay in the air for up to several hours. So if a person who's been contaminated is in a room and then leaves, and then an hour later you come into that room, you could potentially be infected. All right? It's spread through coughing, sneezing, laughing. The reason why we're talking about this today, it's not to scare you, okay? But we work with what is referred to as an at-risk population. Most of our residents here, because of age or other medical issues, their immune systems are not as strong as they once were. So that means that they're more likely to contract certain diseases. And tuberculosis is one that is fairly serious. And because you work with them and come into contact with individuals who are more at risk for contracting this disease, that makes you an at-risk individual, okay? I personally have never known anyone in the healthcare field who has contracted tuberculosis from a patient. So again, we don't say it to scare you, but we want you to be aware of the potential threat there, and so that all of us here at Westminster Canterbury can do our part in making sure that we keep both you and our residents safe and healthy. So tuberculosis, at one point, we thought that we had pretty much eradicated this disease, at least in civilized, modernized countries like our own. But here in the last 10 to 15 years, we've seen a resurgence in the number of diagnosed active cases of tuberculosis in the United States. Most of those cases are in the homeless population, but a fair number of them are in geriatric communities such as our own. And so that's why really we're talking about it today. So some of the signs and symptoms, chronic cough, weakness, weight loss. There are many others, but those are some of the more common signs to watch for. And essentially what's happening is bacteria is attacking and destroying the tissues in your lungs when you have this disease. Again, we already talked about how it spreads, so obviously it can be spread to others. And just so you know, if you've ever had a positive tuberculosis skin test, which is the PPD that you went to the clinic to have done, if you've ever had a positive PPD, you will always have a positive PPD, okay? That doesn't necessarily mean that you have the disease. It doesn't mean that you've ever been in contact with the disease. Some people are allergic to the serum that we use to do the testing. Or it's possible you've been in contact with the disease at some point in your life, didn't realize it, don't have an active case of tuberculosis, but you're testing positive. So if for any reason you've ever tested positive, you will always test positive. And that's okay. It just means that we need to take further steps to rule out the possibility of having an active case of tuberculosis, which usually means that we do a chest x-ray to make sure that you don't have the disease present in your lungs. Okay? It is possible to have tuberculosis and not have an active case, or so it's what we call latent tuberculosis, which means that you are a carrier of the disease but not exhibiting symptoms. Okay? You can have latent tuberculosis for many years without showing symptoms, and then suddenly have an active case of the disease. Some people carry latent tuberculosis for years and years and never show symptoms. So if you are ever told that you have a positive PPD and you have latent tuberculosis, please don't panic. Okay, many people go for years without having symptoms. We do have treatment in the event that it becomes active. Okay, there are medications now that we can treat tuberculosis with. It is a long treatment process, but it is not the same scare that it was 50 years ago. Right. So we've already talked about the tuberculosis skin test, or the PPD. That is what you all have received now and will go back tomorrow to have read. Every new staff member receives 2 PPDs upon employment, right? So we call that our 2-step process. Every new resident that moves into Westminster Canterbury has to prove that they do not have tuberculosis before moving in. So we do our very best to ensure, again, the safety and well-being of not only our residents, but you, the employee, as well. And then every year, we go through all staff and all residents to do a symptom review. So that means if you have had a negative PPD in the past and you can answer no to a list of questions, that you are not exhibiting any of the following symptoms, you've not traveled to any of the following countries in the last 6 months, and then you are deemed to be a low-risk candidate for having an active case of tuberculosis. So you don't have to have a PPD done every year, okay? If you've ever worked in a facility such as this, most facilities once upon a time, even ourselves, used to do yearly PPDs, but now we do them upon employment and then a yearly questionnaire. And as long as you can answer no to all of those symptom review questions, you do not have to have another PPD. Flu vaccines are also required annually, okay? That is mandatory for all staff. Again, that's because we work with an at-risk population. To you and I, the flu is unpleasant. To the people that live here at Westminster Canterbury, the flu could be life-threatening. So we do take this very seriously. We do require that everyone in Westminster Canterbury receive a flu vaccine no later than November 30th. If you have not already had a flu vaccine and have documentation of that, then your managers, once you get out onto the floor, will be working with you to ensure that that gets taken care of. Okay. So there are a few exceptions to that rule. If you are allergic to the flu vaccine, or if you're allergic to any of the ingredients in the flu vaccine, or if you have a documented allergy to eggs, funny enough, if you're allergic to eggs, you can't receive the flu vaccine. Those are all valid reasons not to receive it. And we just ask that you have a physician's note stating to the fact that you cannot receive the flu vaccine. Okay? And so now we're going to talk a little bit about the abdominal thrust and watch a quick video that explains how to perform the abdominal thrust. Most people recognize it by a different name, the Heimlich maneuver, right? And so when do we really think about using the Heimlich maneuver?
When there's a person who are choking.
Yeah, if somebody's choking, right? And so what's the universal sign that someone's choking? Yeah, exactly.
Block of the airway.
Usually they'll put their hands around their throat, maybe they'll point to their throat, okay? Perhaps they can't speak or they'll be coughing. So in the event that you suspect somebody is choking, if they're still able to cough, the best thing you can do is just encourage that person to keep coughing and then notify a trained professional, okay? With that being said, sometimes in instances like this, if somebody's choking, time is of the essence. So we just want you to be familiar and comfortable with the proper procedure for performing the abdominal thrust if you're ever placed in a situation that you feel it's necessary. But please do know that we have many, many trained healthcare professionals here in the event that somebody's having a medical emergency such as choking, who would be prepared to step in and give assistance. But we want to make sure that everyone is aware of and familiar with the abdominal thrust. So we're going to watch a short video here.
First, ask if the victim is choking.
Are you choking?
If the victim nods that he or she is choking and cannot talk, you must act.
I'm going to help you.
When a victim is choking, you need to give thrusts slightly above the belly button. Kneel or stand firmly behind the victim and wrap your arms around his or her waist so your fists are in front. Make a fist with one hand. Put the thumb side of your fist slightly above the belly button and well below the breastbone. Grasp your fist with your other hand and give quick upward thrusts into the stomach. In a real situation, you would give thrusts until the object is forced out and the victim can breathe, cough, or speak, or until they stop responding.
Okay. Any questions about that? All right. So one hand finds the belly button, make a fist right above it, cover it with the other hand, and you're going to go in and up. Okay, and basically what we're doing is we're compressing the diaphragm and pushing air up and out, trying to get whatever object is lodged in the airway out. Okay?
Question.
Yes, ma'am.
What about if the patient is taller than you?
If the person is taller than you, you may have to ask them to sit down so that you're better able to reach around into their diaphragm.
Can you be able to give him or her chest thrust?
Yes, but if they're taller than you, if you can't get around their abdomen, you're probably not going to be able to reach around their chest, right? Yes. And so for some of us, it's required that we're certified in CPR and first aid, and so we have professional training to do this. Some of you may not have that requirement, but we do offer classes here on campus that are open to anyone who works here at Westminster Canterbury if you're ever interested in taking a CPR and first aid course. I highly recommend it for all of us, just because you never know when a medical emergency may occur. And so even though we do have lots of trained professionals here, I encourage everyone just to make yourself aware and be prepared in the event that it's necessary. But it is not required for everyone. All right. So now we're going to talk about dementia. And this is really the purpose of me being here today. So all of the things we've just talked about, they are very important. And I don't mean to diminish their importance. But dementia is it's a big problem in our industry today. So when I say dementia, what's the first thing that comes to mind? What do you think of?
Dementia is a term used to describe that it's occur especially when the declining of the memory and thinking process.
Okay, very good. So most people, if you stop 10 people on the street, probably 9 of them would tell you, oh yeah, that's when you start to lose your memory, right? But is it Merlita?
Yes.
Merlita was exactly right. It actually has a lot more to do than just the loss of our memory, but it also encompasses a decline in our thinking ability. So the exact definition for dementia is a general term or syndrome that is the decline in mental ability that's severe enough to interfere with daily life. Okay, so it is a decline in memory, thinking ability, and our ability to process and to be able to do basic everyday things, such as getting dressed, feeding ourselves, hygiene issues such as showering or brushing our teeth. So it really encompasses our whole way of life. And it's an umbrella term, like we mentioned. So dementia in itself is not a true diagnosis, but rather it's a term that we use to describe several different diagnoses that share a common core group of symptoms. So currently, we know of over 120 different types of dementia. That's a lot.
That's a lot, because I know 4 types, which is the Alzheimer, the Lewy bodies, the vascular dementia, and also the frontotemporal dementia.
Okay.
And the rest I don't know.
Very good. Very good. So those are 4 of the more commonly known ones. I don't even know all 120, okay? But there are 120 different types of this disease, and they all fall under that umbrella term of dementia. So with any true dementia, 4 things are happening at the same time. All right? At least 2 parts of the brain are dying, physically dying. We'll look at some pictures later on in the slideshow of an image of a healthy brain next to a brain that has been affected by this disease. The second thing is that it's progressive, okay? We can't stop it. We do have some medications that are available now that are able to slow down the progression of the disease, but ultimately even those at some point will become ineffective. And then for those of us on the healthcare side of things, something that we need to pay attention to if we're going to be good stewards for our residents is to be aware of the fact if they're taking these medications and they're no longer effective, then we need to reach out to nurses and doctors to have those medications discontinued. Because these medications, for the most part, can be very expensive. And if they're no longer effective, then our residents could be spending a lot of money on a medication that's not accomplishing any good. The third thing is that it's a chronic disease. So like I said, we do have medications to slow it down, but it can't be fixed. We have no cure for dementia. And then last is it's a terminal disease, which is something as a society we don't really talk about a lot when we talk about dementia. but it is a terminal diagnosis. So once you have been diagnosed with a form of dementia, ultimately you will die. And it's a sad fact, but it is a fact that we have to learn how to deal with. Now, dementia is something that we as a society don't really understand very well. For many, many years, billions of dollars have been poured into medical research geared towards cancer treatment, cardiovascular disease, diabetes. But for a large part, this disease has kind of been sitting in the shadows for a long time. Today, there is a much larger emphasis being placed on research into dementia and attempting to find a potential cure. But really, we still don't understand a lot about it. And so to say that there are over 120 different types of this disease, but we don't understand what it is or how to fix it, that's a scary thought. So there's a lot of speculation in the medical world today about what may cause dementia, but no one really knows the answer. There are different forms of dementia that we understand better than others. So for instance, Marlita mentioned vascular dementia. So we know that vascular dementia is caused by many years of hypertension or potential heart attacks and strokes that have happened earlier in that person's lifetime that causes damage to the blood vessels in the brain. And so if the blood vessels are damaged, the brain's not getting enough blood and oxygen, and over time we see the development of dementia. So when I say we don't understand it, we don't know what causes it, we're talking about dementia as that umbrella, but there are certain types of dementia we know more about than others. One fairly popular theory that's being researched right now, and again it's speculative, has to do with the amount of chemicals that we're currently taking into our body through diet and medication and water treatment. So if you look in non-developed nations where they don't have processed food, they don't have water treatment, they don't have easy access to medications, dementia is almost unheard of.
Exactly, especially in my country.
Mm-hmm. And so which country is that, Merlita?
Philippines.
Okay, in the Philippines, for instance. Okay. But then when you look at developed nations, such as our own, where we have lots of medications that we take for lots of different problems, which what are medications? Ultimately, they're just combinations of different chemicals, right? We take them for a good reason to cure other health illnesses, but we also have lots of highly processed foods, we have chemical water treatment, and so on. And so then the question becomes, is it potentially the fact of being exposed to all of these chemical elements that has changed something in our body and brain chemistry? Again, it's just speculation at this point, but there is a fair amount of circumstantial evidence pointing in that direction. Some statistics about Alzheimer's disease, which is the #1 diagnosed type of dementia. Currently, Alzheimer's disease is the 6th leading cause of death in the United States. Of the top 10 leading causes of death in the United States, this is the only one that we don't have a cure or some type of treatment for. So again, that's a scary thought. When we think about our society and this growing problem that we're facing, that we are losing millions of people to this illness, and we don't have any way of stopping it. So currently, 5.3 million Americans have been diagnosed with Alzheimer's disease. 5.1 million are over the age of 65, and approximately 200,000 or so are under the age of 65. Okay. 65 is not very old. It's not.
Right.
65 is the new 45. People are living well into their hundreds. So to be diagnosed with this disease at 65, you could potentially be facing 20, 30, or 40 years dealing with this disease. Now, again, as I mentioned, it is a terminal illness, so most individuals will not live with symptoms for that long, but you get the picture. Now, dementia is not a normal part of aging, okay? A lot of people may say, well, everyone gets forgetful as they get older. And in some cases that is true. There is a normal age-related process of a decline in our memory. Typically it's more related to short-term memory, having a hard time remembering where we put something or remembering when we scheduled appointments. But the amount of memory decline that we see involved with dementia is much more extensive, okay? So it is not a normal part of aging. Currently, 1 in 5 people over the age of 65 are diagnosed with some type of dementia worldwide, and again, these statistics are in developed countries. 1 in 3 people over the age of 85, and new statistics show that we're probably closer to 50% of the population over the age of 85. Okay, so again, those are scary numbers. 65 is very young. Does anyone want to take a guess how old you have to be to live in Westminster Canterbury? Do they still go over that information in NEO? 62. That is exactly right. So in order to live here, you have to be at least 62 years old, okay? How many people do you think at 62 are jumping and rearing to go, saying, I'm going to move into Westminster Canterbury? Okay, we love Westminster Canterbury. It's a wonderful place to live and to work. But 62 is very, very young. So more often than not, the individuals that are moving into Westminster Canterbury are in their 70s or 80s. Okay, so well beyond 65. So if we look at it from that perspective, that means automatically 1 in every 5 new candidates applying to move into Westminster Canterbury is going to have some form of this disease, right? Okay. So 1 in 3 over 85, and like I said, it's really closer to 50%, we believe. And so why do you think then that we pick today of all times to talk about dementia? So we've got people here from nursing, we've got dining servers, we've got housekeeping, we've got a teacher from the child care center. Why do we choose today to talk about this disease?
I guess that's a trend now, because even though that you're young, regardless of age, people sometimes forget. Like what you said, it is not a part of aging. It is not a disease, but we can forget once in a while. So it's important to talk.
So we may not be familiar with the disease or what it means or what to watch for.
Yeah.
But if we look at that, remember, so if we're saying that 1 in every 5 people that's moving into Westminster Canterbury has some form of this disease, that means statistically there are a lot more people who have some form of dementia than we probably realize. And that means that a lot of people are struggling with this disease in our independent living apartments. It's not just isolated to our memory support care centers. And so every single one of us here at Westminster Canterbury will be affected by this disease in some way, shape, or form during your time here. Okay? So housekeepers may be going into apartments where individuals are living on their own without nursing care and struggling to be successful. Dining room servers may see residents coming down to the dining room wearing mismatched clothing because they're struggling to be successful without nursing care. People in the CDC, we have lots of residents who come and volunteer to help out with the small children. So you may encounter residents that are struggling to be successful with some form of this disease. So we just want to raise the awareness, what to watch for, and how we all can help our residents here to live happy, healthy lives for as long as possible. So currently the #1 diagnosed form of dementia is Alzheimer's. We talked about some of those statistics already. The second highest diagnosis rate is for Lewy body dementia. And then there are several other forms. We mentioned 120 different types, but some of the more commonly known ones are vascular dementia, Parkinsonian dementia, or multiple sclerosis dementia. There is also what we refer to as early onset dementia, That is the 200,000 or so people in the United States every year that are diagnosed under the age of 65. Okay? So in the next 10 to 15 years, we expect that these statistics will change drastically. Again, we already mentioned that we believe the numbers for the individuals over the age of 85 are already approaching 50%. But in the next 10 to 15 years, we will hit that 50% mark. And we believe that over the age of 65, so between 65 and 85, those statistics will be closer to 1 in 3 individuals who are exhibiting some type of dementia. So really, as a society, as healthcare providers, this has to be our focus right now because it is a very taxing problem on the healthcare industry. So in the next 10 years, we predict a 40% increase in the number of individuals diagnosed with Alzheimer's disease. Alzheimer's disease, it can only truly be diagnosed after death through an autopsy. So when we diagnose individuals with Alzheimer's disease today, it's not necessarily a definitive diagnosis. So only about 20% of individuals will actually be given a true Alzheimer's disease diagnosis. The other 80% won't necessarily have that diagnosis. They'll be given a diagnosis of just dementia, unknown type of dementia, or some sort of mixed dementia. And so part of the reason why we predict this 40% increase is because of the baby boomer generation. So it's been said that the baby boomers have had a tremendous impact on every industry that they've encountered throughout their lifetime. And our industry is no different. So we have a very large number of people who are quickly approaching the age of 65. And in fact, they believe that, I want to say it's every day for the next 15 years, 10,000 plus people turn 65. That's the baby boomer generation. So every day for 15 years, 10,000 people reach the age of 65, where now we have to start watching for the warning signs that they're beginning to develop some type of dementia. Okay? So when we look at the numbers, it is impossible to think that we will not be affected by this disease. Most of us have probably already encountered this disease. How many of you have had a friend or family member or have known someone in the community? Okay, so some hands have gone up. My grandmother was diagnosed in her 50s, and she died before she turned 65. So many of us have seen the struggle that individuals go through while trying to deal with this disease. So how can we be aware of it? How can we help to support our residents? Well, we want to first make sure that we know what we're watching for. So some of the top warning signs, first, we already talked about what most people commonly associate with dementia as memory loss. All right, we're talking initially about immediate and short-term memory. That's what we're going to see affected in the beginning. But as the disease progresses, eventually we're going to start to see their long-term and emotional memories become impaired. These individuals are going to have challenges in planning and problem solving. And so when we say problem solving, I'm not talking about the ability to sit down and work out complex equations or math problems, but let's say you or I drop a glass of water in the kitchen. The glass shatters on the floor and there's water all over the place. We instantly know, because of years of life experience, I need to clean this up, right? That's dangerous. The individual with dementia drops a glass of water that shatters on the floor, and their brain doesn't have the ability any longer to process what to do in an unexpected situation. Okay? That's the type of problem solving we're talking about. So it could be simple things or it could be big things. And then in that particular scenario, now what happens? We've got broken glass and water on the floor. This individual can't process what to do next. They get frustrated and overwhelmed, and what they do is they just walk away because their brain doesn't know what to do. And now we have a fall risk right?
Right.
It's a safety threat. So for you and I, we have to be problem solvers for these individuals. They're going to start having difficulty completing familiar tasks, especially things that involve sequencing, things like getting dressed in the morning, right? You and I know we wake up, we shower, and then we have to put on our underwear, and then we put on our pants, and then we put on our shirt, right? The individual with dementia now has a hard time figuring out what order things go on in. So you may have somebody who comes down to the dining room with a pair of slacks and their underwear on the outside, right?
Right.
Because they have problems with sequencing. Anything that goes outside of their normal routine, they're going to have a difficult time accomplishing. They'll start exhibiting some confusion with time and place. For us, this is where we practice what we call validation therapy. So the slide here says we must meet them where they are. And so really what validation therapy is, once upon a time we, as medical professionals, thought the best thing you could do for these individuals was constantly reorient them to reality. It's called reality orientation therapy. So if Mrs. Jones comes to the dining room and thinks that it's 1965 and she's at a diner in Chicago, your job was to tell her, no, Mrs. Jones, it's 2018, you're at Westminster Canterbury, you're here for dinner, right? But we don't do that anymore because what we found was, A, you'd constantly be reminding them of when and where they are, and it caused more emotional trauma than it did any good. So what we practice now is called validation therapy. And essentially what that means is, just like the slide says, we meet them where they are. So if a resident comes to you and they think that they're in a diner in Chicago in 1965, then guess what? We're in a diner in Chicago in 1965, right? So as long as it doesn't pose an immediate threat to that resident or another resident, what harm does it do to meet them where they are? Okay? And chances are in the next 10 to 15 minutes, that resident is no longer going to remember what they were focused on, and so now they're sitting at the dining room table getting their meal, they're happy, they're distracted, and we didn't have to cause them any emotional trauma by orienting them back to reality. Individuals will begin to have trouble with visual images and spatial relationships. And so what I mean by spatial relationships is so the example that's given on here is the pattern in flooring. So I always like to talk about when I was a kid, my mom used to take me to the department store, and you remember they used to have the big black and white checkered tiles on the floor. And when I was a kid, I would hop from one white tile to the next, and you weren't allowed to step on the black tiles, right? Because there really wasn't any floor there. Well, our brains process and know that there really is floor there, right? I was a kid. That was a game that I played. The individual with dementia, though, their brain doesn't have the ability to process abstract thoughts. So let's say that resident with dementia walks up to that same black and white checker tile floor, and they walk up to that black checker, and even though we know that there is actually something there, their mind processes that as a hole in the floor, a true hole in the floor. And so they won't go around it. They won't go over it. They'll find some other way of getting to where they're going. And so that can cause difficulty for day-to-day living. And so one thing that we here at Westminster try to pay a lot of attention to is our choice of decor, especially in our memory support areas, to avoid carpets or flooring that have intricate patterns. We try to keep things nice and bland and neutral so that we don't create problems for our residents. Another very common sign, word finding difficulty. So we also sometimes refer to it as word salad. For instance, you may have a resident who can tell me 10 different words to describe the pen in my hand, but they can't tell you it's a pen. It'll be, that thing, you write with it, it's like a pencil, but it doesn't have an eraser, you put ink in it. They'll be able to tell you all these different words to describe it, except for the one that they're looking for, and that's pen, right? Eventually that gets worse over time, and they start to just have very jumbled gibberish. And that's really what we refer to as the word salad. But in the early stages, they'll be able to carry on a conversation, but they won't be able to think of the right words at the right time. And so they'll insert synonyms or other words to describe the word that they're trying to think of.
So that's going to be the 4 A's of dementia, right? So which is what you call it, they cannot be able to know that they know the thing, that they can feel it, but they don't know the particular name of it.
Mhm.
It's agnosia,
Yes,
which is
yes,
the
ma'am. Mhm.
amnesia, aphasia, agnosia, and aphasia.
Yes, ma'am. Yeah. That's a little more detailed than what we go into today, but yes, that's correct. Another common warning sign, these individuals that have been affected by the disease will begin to misplace items frequently. They'll have a hard time retracing their steps. And so again, we talked about this isn't part of the normal aging process. So misplacing items is not necessarily an indicator that someone has dementia, right? I lose my car keys all the time. But when I lose them, I have the ability to sit down and think, okay, where was the last place I had them? I came home from work yesterday. I set my things down on the chair. I grabbed my son. Oh, they must have fallen into the chair cushion, right? So we can trace things back. These individuals, when they misplace items, they don't have the ability to sit down and trace their steps back the day before to try and locate something. And unfortunately, something to be aware of as caregivers, when items become misplaced, very often the natural instinct for these individuals is to accuse someone of stealing them, okay? So my words of knowledge from many years of experience, if you're placed in that situation, please don't take it personally. The resident doesn't mean anything to harm you or to be hurtful. It's the disease. It's not the person, okay? And it's an unfortunate reality that is going to affect us in our line of work. These individuals also begin to exhibit decreased or poor judgment. They have a hard time making decisions, and not just making decisions necessarily, but making safe and rational decisions, okay? So for you and I as the caregivers, we really have to help and guide these individuals to make safe, smart decisions for themselves. They really don't understand cause and effect. They're not going to be able to see anybody else's point of view or to reason on anyone else's point of view. Once they make a decision, that's the decision. Doesn't matter what you have to say. They will oftentimes begin to withdraw from work and social activities. Many times, the first sign of dementia that we see is when a resident's loved one or family member calls us and says, you know, I think mom is suffering from depression. You know, she used to go to church every Sunday. She's been religious for the last 65 years. She never missed one single meeting. And now all of a sudden she doesn't want to go anymore. Okay. Sometimes the early signs of dementia do mimic some of the warning signs of depression. And that is because in the early stages of dementia, more often than not, the individual is aware that they are going through changes. And oftentimes, they are having a difficult time processing and coming to terms with that reality. And so what happens is they begin to isolate themselves from friends and family members because they don't want anyone else to see the changes that they're experiencing. It is true, sometimes depression in itself can cause some memory loss, but more often than not, when you begin to see those signs, especially if you see this in combination with any of these other warning signs that we've talked about, then it's typically a warning sign that they're experiencing some cognitive changes. And then the last one, these individuals will begin to experience changes in their mood and personality. And again, so a lot of that has to deal with the fact of being able to process and come to terms with the changes that they're experiencing. And so if you place yourself in their shoes, imagine how frustrated you would be if you were no longer able to wake up and get yourself dressed in the morning. Or imagine how humiliated you might be if you did show up to the dining room with your underwear on the outside. So these individuals will experience mood swings, personality changes, but again, please don't take it personally. It is the disease, not the person. So really, we have to change our mindset, and what we're trying to do here is to build the culture that this is a disease and that the person is no longer in control, okay? And it's our job to help that individual to cope with this disease as best they can so that we can maintain some semblance of control. So we already talked about the fact that the brain is dying, okay? In many cases, most individuals are aware, at least in the early stages, that they're beginning to lose control. And because of that awareness, oftentimes depression and frustration become daily issues that we have to work with. So as caregivers, we have to remind ourselves, we have to remind the family members and friends, the loved ones that are surrounding this resident, that that person is no longer in control. And so sometimes that's a lot harder for the family members to process than it is for us, right? Because typically we don't have established relationships with these individuals before they come into our care, right? Family members have lived with this individual and have known them a certain way for their entire life. And now suddenly their entire personality has changed. So that can be really difficult to process. And so we are here as a support for the families just as much as we are for the residents. For the resident with dementia, remember, so we're never going to correct them. Right? We practice validation therapy. We want to meet them where they are. And just remember that they're doing the best that they can. Okay. So I told you earlier we were going to see some images of the brain that's been affected by dementia. So here on the right we have a normal brain, and here on the left is a brain that's been affected by Alzheimer's disease. What's the first thing that stands out to you that's different?
The normal brain is big and the Alzheimer brain is getting smaller.
Yeah, yeah. So the size difference, not only the size difference, but the neural pathways, right? You see the areas in between the gray matter now are actually expanding. And so it makes it very difficult for communication to happen from one cell to another in the brain, okay? So the brain is literally dying. And these are some more illustrated examples. And this points out some of these specific areas of the brain that are being affected. Okay, and then here we see the language center, which we're going to talk a little bit more about here in a minute, the temporal lobe, and really the memory processing center in our brain, which is the hippocampus. So, how does the cell death in the brain affect the body, the person, okay? So communication with anything that we do in life is very, very important, right? You cannot expect to really accomplish much of anything successfully if you don't have the ability to communicate. That's what sets us apart from the animals. It's our ability to communicate with one another. 7% of communication is formal language. All right, so that's the words that are coming out of our mouth. And that means that 93% of communication is nonverbal. All right?
Or body language.
Body language, tone of voice, hand gestures, facial expressions, all of those things go to emphasize the message that we're speaking. Okay? So it's important for the individual that's been affected by dementia to understand that they're going to have a hard time communicating, okay? And then we need to be aware of the fact not only are they going to have a hard time communicating because of the cell death in their brain, They typically will hear lower tones better than higher tones. That's true for the geriatric population in general, but it just even more applies to individuals with dementia. We want to keep the number of words that we're using to a minimum, okay? Remember, they have word finding difficulty. The center of the brain that processes formal language is beginning to die. So if we're using or giving complicated instructions, chances are they're not going to understand what we're saying. So we want to try to speak using clear, simple sentences. We always want to use multiple forms of communication. And so what I mean by that is using those forms of nonverbal communication to emphasize the message that we're trying to send. If somebody gets it wrong or they don't understand what we're trying to tell them, right, we never want to correct them. You don't want to make them feel stupid or childish, right, because ultimately that's going to lead to frustration on their part, and then we're just building barriers to communication rather than helping. But we just want to be patient and take a step back and look at, okay, what can I change about the way that I'm communicating so that we can be more successful, right? And then the last bullet here, I love it. Smiles are free, and it's always a good idea, right? So it sounds kind of silly, like I see kind of laugh a little bit, but if you walk into a resident's room with a genuine smile on your face, 9 times out of 10, you're going to have a positive interaction with that person, right? Versus if you walk into their room and you're carrying the weight of the world on your shoulders, you had a bad morning, you're grumpy, you forgot to make your coffee, you burnt your bagel, right? It's amazing how these residents, despite all of the challenges they're facing, they can read people. And if you walk into their room and you're sad or depressed, they're going to pick up on that. But they don't always understand that there are circumstances outside of here and now that may have led to you being in a bad mood. And so what ends up happening is they associate it with themselves. So smiles are free. It's always a good idea. And if you can start every interaction with the resident with a smile on your face and genuinely mean it, you're more often than not going to have positive interactions. So some of the specific areas of the brain that we're dealing with, the frontal lobe of the brain, this is the executive control center. This is really what controls our perspective, our decision making, our ability to multitask. It's also what controls our impulse control, okay? So that's something else. As this particular area of the brain is affected by the disease, impulse control goes out the window, right? So impulse control comes into play in a lot of different ways. So when we were kids, right, growing up, did anybody ever stick their hand onto a hot eye on top of the stove and burn yourself? Right? That was because as children, we're still developing our impulse control. And so we see something bright and red and we want to touch it. But then through life experience, we learned, oh, that hurt, so I'm not going to do it again, right? We have the ability to control that impulse. Well, these individuals, that impulse control is gone. So they see that red hot eye on the stove, and now maybe because their impulse control is gone, they don't remember that life experience, they're drawn to it and they want to touch it, right? Or impulse control could be, right, the choice of words that comes out of our mouth, right? If you're having a bad day and somebody cuts you off in traffic, you might be really tempted to shout some nasty things at them, but it's our impulse control that gives us the ability to restrain ourselves, right? Again, these individuals don't have that impulse control. So you might hear some things come out of their mouths that maybe ordinarily wouldn't. Okay? So with dementia, obviously, we already talked about they're going to have a hard time making decisions. They're not going to be able to really see someone else's point of view or to reason on it. So try not to be argumentative with residents. If you have a resident that is being argumentative or not cooperating in care, the best thing you can do is to just give them some time alone, walk away, and then try to reapproach them again later in the day and see what you can accomplish. The temporal lobe, all right, this is the language control center. And so you saw from the illustrated pictures that this is one of the particular areas that's being affected by the disease. It's shrinking, right? So we talked about word finding difficulty. That's because the amount of brain cells that are in that particular lobe to store our vocabulary is now somewhat limited. So they begin to lose their vocabulary. Both sides of the temporal lobe are different, and every individual is different in how they're affected by the disease. But in most cases, the left side of the temporal lobe is affected more so than the right. The left side is what controls our formal language. And that's really why we start to see those word-finding difficulties, the difficulty in communicating. And that's because this left side has been affected and now their vocabulary is slowly shrinking, right? The right side of the temporal lobe in most individuals is not affected as significantly as the left side. And the right side is, this is where anything like automatic chit-chat, anything rhythmic is stored here. It's also where what we call the forbidden words are stored. And so that's those things like, you know, those nasty cuss words that you wanted to shout in your car when you got cut off in traffic, right? Whether or not we choose to use those words in our day-to-day vocabulary, we all know them, right? We grew up, we heard them from other people, and then mom reinforced, you don't say that, that's bad, right? But what happens is these individuals are losing their vocabulary, but they still have a need to communicate, right? Human beings are social creatures. We have a need, a basic need to communicate with other human beings and to socialize. And so these individuals are going to try to communicate with whatever words they have left. And sometimes those words are not so pleasant. So you will find some of the sweetest, nicest little old ladies in the world that cuss like sailors because they're communicating with the only words that they have left, right? And again, that's going to go back to helping the family members to come to terms with that, because that could be very unusual from what they are used to experiencing with their parents, right? And so again, also don't take it personally. It's the disease, not the person. Also, the fact that this right side is not affected as much as the left side, that's why music therapy can be so beneficial to individuals with dementia. Oftentimes, if you go walking through one of our memory support units, you'll hear soft melodies playing in the background. And that's because, again, the ability to recognize the rhythm and tone from songs, that tends to stick with residents. And also, music is a very emotionally charged thing, right? You know, we may hear a song that perhaps was played on our wedding day, or it's something that we used to sing with our mom or dad when we were growing up. So those songs can sometimes carry a lot of emotional memories, and so it's tied into those long-term memories that tend to stick around longer for residents. The hippocampus, this is really where the primary bulk of our memory is stored in the brain, okay? And so for many forms of dementia, this is the area that is the first indication of a problem. So the first thing that we're going to see is an inability to hold on to new information, right? So that short-term memory is out, that's gone. We're not going to be able to remember appointments. We're not going to remember where we set our keys down last night. You're not going to remember what you ate for breakfast this morning, very likely. But the long-term memory tends to stick around. Eventually, those older memories and those emotional memories become impaired as well. And so memory we think of in linear terms. So I always explain it like a film reel, like the old movie reels when you went to the theater. It was just a big reel of individual images. And as the reel spins, right, it shows a moving picture. So if you think of your memory like an old film reel, And in the beginning, we're just basically cutting off the slides on the end of the roll, whatever's happened most recently. But eventually, as the disease progresses, it starts to affect some of the older slides. But it doesn't have any particular rhyme or reason to what memories are affected. And so what happens is you start to lose a slide here, you lose a slide there, maybe you meld these two slides together and form a new memory, right? And so eventually what starts to happen is individuals begin to experience what has been referred to as this time traveling sensation. So let's say, for instance, you wake up in the morning, you're eating breakfast, and then you have no recollection of anything that happened that day in between breakfast and when you went to bed. And now all of a sudden you wake up, it's pitch black, you don't remember anything. The last thing you remember was sitting at the breakfast table. You don't recognize where you're at, and there's a strange nurse peering over your bed making sure that you're okay. And so it seems as if you instantly transported from that dining room table to your bed in the middle of a dark room. Can you imagine how frightening that would be? So can you imagine why some of our residents that have been affected by this disease exhibit so much anxiety and some of the other behavioral issues that we see? So that's really a frightening thought. But it's because of that time traveling type of sensation. Right? The next area of the brain we're going to talk about is the occipital lobe. And so this is really what gives us the ability to process information. So what happens is light and sensory information goes in through our eyes, it's collected and processed and sent through the occipital lobe to our brain, where we translate it into a picture that we see. So as the occipital lobe is affected by the disease, the first thing that starts to go is our peripheral vision. So that's your ability to see stuff out here on the sides, right? So if you wave your hands out here and look straight ahead, you can still kind of see that they're out there. That's what the DMV tests for when you go to renew your driver's license, and they have you look into that thing. So we start to lose our peripheral vision. That's true for people as we get older in general, but it's exacerbated by this disease. Eventually, they're going to end up with what we refer to as monocular vision. And so what that means is, so if you hold up your hands like this, right, this is all that they have in their field of vision now. Nothing out here, it's all gone. This is all they can see. And so if you walk through some of our memory support areas, a lot of times what you'll see is now you've got, perhaps that resident suffers from arthritis or maybe scoliosis, they've got a bad back, maybe they use a walker, and they are a little hunched over, right? And now they've lost their peripheral vision. And this is all they can see. And so you watch them and they'll shuffle their feet very slowly, one step at a time, as they stare straight down at the floor. Because if they're looking up here, they can't see where their feet are going, right? You and I, we have the ability to hold our heads up and walk, and we can kind of see what's down in the floor at our feet. We're not going to run into anything, right? These individuals don't have the ability to do that anymore. Another difficulty that will arise, they have a hard time recognizing and using utensils in the dining room, cups and forks and things, because they'll pick them up and maybe miss their mouth. And so that is really a dignity issue. So we try to set up our dining areas to make things as easily visible as possible for these individuals. All right. The next piece of the brain that we're going to talk about is the sensory strip. And so that runs down the middle of our brain from the top down on both sides. And this is what controls sensation and movement. Okay. So over time, while this connection is destroyed with dementia, it causes difficulties. Individuals with dementia, oftentimes because they are beginning to experience difficulty with movement because of the destruction of this connection, they'll lay in one position for hours on end. They lose some of the sensation, so they they don't notice that body parts are beginning to hurt because of lack of circulation. And again, so then it becomes our role as the caregiver to make sure that those individuals are getting up and moving around, and that we're encouraging good circulation to all of the extremities and body parts. And also leads to hypersensitivity in terms of auditory and visual input that we're receiving. And so what that means is if a resident with dementia is in the middle of a crowded room where there's a lot of conversation, loud voices going on, it becomes very overwhelming for that individual. Their brain can't process all of the different voices talking at the same time. And so that can oftentimes lead to that particular person having some negative behaviors or negative reactions because they're overwhelmed and their brain just can't process what's going on. So try to be mindful of that. If you're ever working in any of our memory support areas, we try to keep things as calm and quiet and peaceful as possible to avoid overstimulating individuals. So, just kind of to sum things up for us, we try our best here at Westminster to create a place of success for the residents, all right? And really, no matter what our job is here, it's all of our responsibility to try and do what we can to support these individuals. So our job is to adjust to their world, not the other way around, right? This is their home, we just work here.
Yeah, we're here for them.
We're here for them, right? So especially on the caregiver side, right, it can be really easy for us to get caught up in what we have to accomplish each day. I come to work, I've got 8 patients that need a bath this morning. I've got to get 16 people down to the dining room for breakfast. I just don't have time. But remember, their routine trumps what ours is. Okay? So however much time it takes, we take that time to help that person be successful. We try to pay very careful attention to lighting and decor, the colors of the walls, the type of flooring that we use. So remember, we talked about not having very intricate patterns in the carpet or in tile flooring. We didn't talk about this, but actually scents, right? What we smell, our olfactory nerve, that can also oftentimes be tied into memory as well. And so a lot of times you may walk through a memory care unit and maybe you'll smell cookies baking in the oven or some type of pleasant scent. So aromatherapy can be very helpful for these individuals. We want to make sure that any clocks or phones have large, easy to see numbers on them. Try to set that person up to be successful. TV, again, we want to make sure that if a resident enjoys watching TV, that the screen is large enough that they're going to be able to see it and enjoy it. Music in the dining rooms for meals can be very helpful, very tranquil. And so really just to remember, dementia is not so much, our focus should not be so much on what that person can't do for themselves any longer, but we want to remember that they're still a person. They still have a lot of wonderful qualities about them. And we just want to help to focus on what they can do, help them to do it by themselves successfully, and then help them with the pieces that they're no longer capable of doing. So Teepa Snow is a very well-known dementia practitioner here in the United States. She's actually on the, she is an instructor at, I want to say it's Duke University. It's either Duke or UNC. And if you ever have the opportunity to watch any of her lectures, she talks about what she calls her donut theory. And essentially that she says, when you go to a bakery and buy a donut, what is it that excites you about that donut? It's not the hole, what's missing in the middle, but it's the donut itself. That's the tasty portion, right? And so with individuals with dementia, we don't want to focus on the whole. We don't want to focus on what's not there. We want to focus on them. We want to focus on the donut. What are they still capable of doing? Who were they as a person before this disease? And then that's really going to help us to serve their needs better. Again, remember, it's a progressive and terminal disease. So sadly, no matter what we do, ultimately, it is terminal, but we want to make sure that we give that person the highest quality of life possible while they are progressing through this disease. And so these are just some tips that some TIPA Snow has for individuals that are interacting with residents with dementia. So for instance, you always want to try to approach from the front. We don't want to catch those residents off guard, because remember, again, they have a hard time problem solving. Anything that's out of their routine might overwhelm them. So approach from the front so they can see us coming. You move slowly. Make sure that you have good eye contact and visual cues. Now with eye contact, also it's important to pay attention to culture, because in many cultures, especially some Asian cultures, eye contact is actually, it's not considered to be polite, right? And so we want to make sure that we are being respectful of where that individual came from. So in American society, eye contact is considered the norm, and it would be rude to not make eye contact, whereas if you're dealing with somebody from another culture, that may not always be the case. Always try to greet residents by their preferred name. When individuals move in here or whenever you start working, it's good to establish those relationships with your patient. And it's okay to ask them, Mrs. So-and-so, what do you prefer to be called? And usually they'll tell you. And just don't be surprised, though, especially with women, if the name that they give you is not the name you're expecting, right? Because what happens a lot of times is individuals were married for many, many years, and now maybe a spouse has died and they're living here by themselves, and they've forgotten their married name, and they revert back to using their maiden name, because that's the older memory, the one that's still intact, right? And so just be aware of that and be careful. We don't want to call them by a name that they aren't expecting. It's touch, so it talks about using handshakes here to connect physically to the residents. Touch is a very helpful tool as a caregiver. Again, I talked a little bit about it earlier. Human beings are very social creatures, right? We crave connection with other human beings. That doesn't change just because they've got dementia and now they're living in a facility like ours. But my one caution when using touch as a caregiver is you always want to make sure that it's okay with that person, that you touch them before you reach out, right? Because otherwise it could lead to a negative reaction. All right. Oftentimes they like to touch you, but maybe don't want to be touched themselves, and that's okay. Remember, never correct them. We just want to meet them where they are. Individuals that do become agitated, just acknowledge that, right? We want to make sure that they understand that their feelings are important to us. And so just acknowledge how they feel and walk away. Give them some time to calm down. Try to come back and reapproach them a second time. Or if you have the ability, maybe we can have somebody else come back and reapproach them. Sometimes a different face is all it takes. Remember, crowds and loud noises can oftentimes be overstimulating. And they're going to process communication very slowly, okay? So we talked a lot about the lack of vocabulary and how we can reinforce our message with nonverbal cues, but we want to be very slow and clear when we do try to communicate with these individuals. Use a friendly, lower tone of voice if we can. Try to reflect their emotions and again, acknowledge their emotions. We want to make sure that just because this individual has dementia, right, their feelings and thoughts are still important, and we want to make sure that they know that. Don't be in a hurry. So again, we talked about it. As a caregiver, you're going to have a million different things you have to do every single day, right? But if you walk into a resident's room and you're in a hurry, they pick up on that. And we don't want to make them feel like they aren't deserving of our time, right? So we want to give everybody the time and attention that they deserve. And then these are just really some more helpful hints and tips. So the best thing that I can say to you is, try to be aware of the disease, watch for the warning signs. For those of you who aren't in the caregiver side of our work, if you encounter a resident who you think may be experiencing some changes cognitively, reach out to the nursing staff, reach out to the nurses in the clinic, and it may very well be that that person's already receiving help. But we want to make sure that we don't leave anybody out there to struggle with this disease on their own, because we do have supportive services here to help them be successful. All right. And just, like I said, don't take it personally, because ultimately that person's not in charge anymore. The disease is running the show, and we are just here to help that person to live a happy life. All right.
Exactly.
Any questions?